Look at this pump expanding and contracting. To move fluid, it requires one very simple thing: empty space. It needs room to expand to draw fluid in, and completely clear pathways to push it out. The human heart works on the exact same mechanical principle. Surrounding the heart is a structure called the pericardium. It is a tough, fibrous envelope that wraps around the outside of the heart muscle, separating it from the surrounding mediastinal structures in the chest cavity. The pericardium provides a smooth, frictionless environment for the heart to glide against with each beat. Yet, strangely, it is entirely optional. Cardiac surgeons can leave it wide open at the end of an operation, and the patient will suffer no ill effects. But when things go wrong, this envelope creates a serious physical vulnerability. Because the heart is trapped inside this closed space, and its interior consists of tight, closed loops, its operating room is easily compromised. Often, catastrophic mechanical failure occurs because the heart's required physical space has been invaded, even while the muscle tissue itself remains perfectly healthy. Let's zoom in on the exterior boundary of the heart. Between the thick muscular wall and the outer pericardial envelope, there is a microscopic sliver of space. Normally, there is a continuous, balanced cycle of fluid production and resorption here. This cross-section shows what happens when disease disrupts this balance. Fluid accumulates between the layers, creating a pericardial effusion. When fluid pressure exceeds the atria's internal pressure, the walls yield, a critical state called tamponade. Consequently, receiving chambers are compressed, and venous return plummets. If the fluid builds up very gradually, say from a slow-growing malignant infiltration, the human body can adapt. The pericardial cavity can stretch to hold up to 2 liters of fluid before tamponade hits. But in acute situations, like penetrating trauma or a postoperative bleed, a tiny volume of blood accumulating in minutes will cause systemic collapse. Clinicians look for specific warning signs of this pressure trap: critically low blood pressure, a paradoxical pulse, and Kussmaul's sign, where the jugular veins in the neck bulge during inspiration because the impaired heart cannot accept the incoming blood. In tamponade, the heart muscle itself is entirely healthy. The pump is simply being crushed from the outside in. This anatomical map shows the emergency intervention for acute fluid compression: pericardial aspiration. A wide-bore needle is inserted just to the left of the xiphosternum at the base of the ribcage and advanced carefully toward the tip of the left scapula. To prevent the needle from piercing the healthy heart muscle, doctors attach an ECG electrode directly to it. The monitor will spike the exact second the needle tip grazes the heart tissue, signaling them to stop and drain the fluid. Fluid isn't the only external threat. In a condition called pericarditis, often following a viral illness, infection and inflammation attack the envelope itself. In chronic cases, the normally flexible envelope thickens and turns into a rigid, non-compliant shell. The heart can no longer move freely within it, severely reducing the volume of blood it can pump out with each stroke. Whether the surgeon is slicing open a rigid inflammatory scar or draining trapped fluid with a needle, the medical objective is identical: release the external trap. We can move past the muscular wall and step directly into the hollow inner chambers of the heart. Here, the physical architecture faces a different kind of threat. In patients with poor ventricular function or irregular rhythms like atrial fibrillation, blood can pool and stagnate. This allows dangerous thrombi or blood clots to form and lurk within the chambers. The chambers can also be obstructed by tumors. The most common benign cardiac mass in adults is the atrial myxoma. Take a look at this cross-section. An atrial myxoma is a neoplasm that frequently grows into an ovoid mass hanging from a stalk, creating a pedungulated tumor. With every heartbeat, it swings downward like a pendulum, physically obstructing blood flow through the heart valves. Children face a different benign tumor called a rhabdomyoma, which typically grows as multicentric masses in the lower ventricles. On rare occasions, primary malignant tumors like angiosarcomas develop, carrying highly aggressive traits and poor outcomes even with aggressive treatment. These internal masses turn the heart's own internal geometry against it, transforming wide-open fluid pathways into plugged, deadly bottlenecks. Caught between the external pressures of a shrinking envelope and the internal blockages of its own chambers, the heart is a highly vulnerable system. Whether suffering from tamponade, a rigid pericarditis scar, or a swinging myxoma, the underlying danger is entirely mechanical. It is a failure of physical architecture. This fluid dynamics model illustrates the ultimate solution. Saving a patient in any of these crises relies on a singular physical goal: clearing the way and restoring the vital empty space the heart needs to do its job.
If you like this video, give us a thumbs up